And so let's jump right in. Tell us a little bit about your current practice as far as spine and bone tumor ablation.
Sure. As you know, we've got our own outpatient IR center, and I've got a hospital where I do some cases, and we've got an ASC where I do some cases. The main place where we try to do these is in the outpatient center because it is so much easier to do it when you control the staff, when you control the schedule, and it just works a lot better. As far as practice building, essentially what I do is I look at all the MRIs of the lumbar spine that are done on patients when they come across both at our imaging center and at the hospital. And I'll look through and I'll look for any bone tumors. And if I see a bone tumor, I will call the referring doc and say, hey, by the way, your patient has this in their lumbar spine. Would you like me to do something about that? That's basically the same approach that I use for kyphoplasties, for compression fractures. And it works pretty well to the point where now I'm starting to get referrals from the oncologists who say, hey, this patient has some bone pain. Let's send him over. This is something, I think this is an important practice building point to keep in mind. Your oncologists want the patients to be able to sit still to get their chemotherapy. Your standard radiation oncologist, 75% of their business is painful bone meds. So if you come in and say, hey, I'm going to be taking over the treatment of painful bone meds, you're going to have a lot of radiation oncologists who are not happy with you. So you need to couch it in a different way than I'm going to help take care of these painful bone meds. What you need to point out is I'm going to make it so they can hold still on your table to get their radiation treatment. Because if they can't hold still on the table for their radiation treatment, that's a problem. The other thing is making sure that you're letting them know this is not something to replace what you're doing. This is something to augment the effectiveness of what you're doing.
Complementary rather than exclusionary.
Exactly. And that is something that you need to make sure that you are talking with your friendly neighborhood radiation oncologists about from the get-go. If you're going to be doing bone tumor ablation, you need to get your radiation oncologists on board because otherwise it's going to be a really ugly turf battle.
How did that process go for you? Did you reach out to individuals?
Oh, yeah. Well, I went and I presented to the radiation oncologists. I went and brought the radiation oncologists in and we brought them lunch and said, hey, listen, this is a service that we offer. It helps to get the patients pain-free a lot quicker than whatever it is that you're doing, which means that they're going to be able to hold still for your treatment. I'm not claiming that I'm killing the entire tumor. I'm just making it so that they can get themselves taken care of. The way I explain it to the patients is, in your house, if you've got a weight-bearing wall and one of the beams is full of termites, I'm going to go in and rip out that beam and put in some cement to hold it up. But you still need to fumigate the house. And that's where your standard medical oncologist comes in. And I explained to the radiation oncologist, I'm just going to get the one beam. You've still got to blast the whole wall to make sure that it gets taken care of.
Right. That's a great metaphor. I really like that. I think I'm going to steal that one.
It's not patented. The other thing that I think is important is the trials out there all support radiofrequency ablation of bone mets as giving quicker pain relief than radiation therapy, and it lasts a long time after you do that. The Opus 1 trial is the big one that came out. It's 200 and something patients who they did radiofrequency ablation on, and it is a very good trial. It shows that at 3 days after the treatment, patients are doing significantly better as far as pain and quality of life. And in general, it takes radiation therapy a month to get there. So it is undisputably something that works better as far as taking care of the patient right then and there if they've got things going on. Now, in the spine, there's a couple of things to keep in mind. If it is a patient who has neurologic symptoms from this tumor, that is not my patient. They need the radiation therapist and they need the surgeon to decompress them, because if they've got, I'm not going to do them any favors by going in and trying to burn them if they've got neurologic symptoms.
Sure. And you're talking about myelopathy related to cord compression predominantly.
Right. If they've got, you're going to check anal wink reflex. If they're incontinent of stool because their cord is compressed, that's not going to be something that I'm going to fix for them. That's something that they need a surgeon and radiation oncologist. Leg weakness, iffy, but those big cord compression things, that's a red flag. That's somebody else is going to be dealing with that issue.
Sure. And when you are, as you mentioned earlier, reading the actual studies and seeing what's going on, you take obviously a diagnostic radiologist eye to that. And have you dabbled with anything like the SIN score, or tell us about just generally what is your process for assessing these tumors on the imaging?
Is it replacing the marrow signal on T1? That's the big thing that I'm looking for. Is there a fracture line? That's the other thing I'm looking for. Is it pooching into the spinal canal? Because sometimes it's okay for it to be pooching out a little bit into the spinal canal. I can still burn it and get a good result. If it is going up the pedicles, that tends to be something that requires a little bit more finesse to take care of. As in, you've got to burn the pedicle on your way out in order to treat that. Those are the big ones that I'm looking for. Is, does it look like they're compression? And does it look like they are actually getting a fracture? Because a fracture is always going to hurt, and that's something that I know that I'm going to get a good result treating. If it's a painful bony met, that's the question. I mean, because there's a lot of people who've got mets all over the place that aren't painful.
Exactly. That was my next question, is when you have a patient who has multifocal metastases, how do you kind of narrow, and there's not a pathologic fracture, what's your process for kind of narrowing down?
Physical exam. It's basically, I know.
Yeah.
Who does that anymore? Gross.
As a radiologist, I can't even spell physical exam.
No, physical exam is the key to it. You push on their back and find the spot that hurts is the quick and easy way to do it. And I've gotten pretty good at that, and my PAs have gotten pretty good at that. We've worked with the PAs very closely on this. So painful bony metastases, especially if they've got an associated pathologic fracture. Here's another plug that I'll put in. I've told my PAs and I tell myself, if you are using the words radiofrequency ablation of bone tumor, the next words out of your mouth need to be what? Pain pump.
Great plug.
Because if you have a patient who has painful bone mets, they're not going to be well controlled on their pain. So I tell my PAs, and I follow this rule myself. If I am using the words osteocool radiofrequency ablation, the next words that I'm going to say are pain pump.